Thank you for joining us. We'll get started in just one more minute. Joining us. This is Marcella McGuire from the Corporation for Supportive Housing. We are here to talk today, thanks to the support of HRSA, about the webinar series on addressing the opioid crisis. CSH and the National Healthcare for the Homeless Council is co-sponsoring this webinar series. This is the first in a series of 3 webinars. Our first webinar will focus on the Support Act 2018. Folks saw the opioid bill, the opioid law passed in October of this year. We're going to talk today about what are the new resources that are available, what are health centers and healthcare for the homeless sites in particular seeing in regard to the opioid crisis, and then get a really deep understanding about how the resources from that new federal law will flow to states and will flow to local communities, and how you can get involved in your own local community to get engaged around that practice and influence how those resources are used in your community. So I'd like to, this is a 3-part series. Our first series, our second, we're talking about resources today. We're going to talk about systemic responses in another webinar that you'll see coming out from CSH and National Healthcare for the Homeless Council in February of this year. And then we're going to be talking about best practice models in April of 2019. So thank you for joining us, and stay in touch either through Healthcare for the Homeless or CSH to get the exact dates and details for our next webinar series. I'd like to introduce our panelists today as well, and who's part of this. Our panelists today are Barbara TPHO. Barbara's the Senior Director of Policy for the National Healthcare for the Homeless Council. Rob Morrison is the Executive Director of the National Association of State Drug and Alcohol Abuse Directors, and Melanie Whittier is the Director of Research and Program Applications, also with the National Association of State Drug and Alcohol Abuse Directors. We also have Sue Augustus, who's managing our chat, Jennifer Yang, who's managing our technology, and Brett Poe from National Healthcare for the Homeless Council, who's going to be managing the discussion portion of our presentation. So with that, we thank you for joining us today, taking this time on a Friday before the holiday season. And with that, I am going to turn it over to Barbara to get us started.
Great. Thank you, Marcella. Really excited to be here today and talking about health centers, the opioid crisis, and some of the resources that are available to the community, as well as talking about some of the legislation that's passed, particularly the Support Act some months ago. And so just really quick, there's likely a number of folks on the call who are already familiar with health centers, but for those who are coming from more of a COC provider or housing background, just a quick reminder, the role of health centers is providing primarily primary care, preventive services in terms of chronic disease management, health education, a lot of support services, particularly to underserved populations. And so most of the folks that we see are under the poverty line, but health centers are also required to serve everyone, regardless of ability to pay and regardless of insurance status. Our boards of directors are generally patient majority boards. The exceptions for that are in many healthcare for the homeless grantees may have different ways of engaging consumers in the decisions that run the health centers, but very consumer engaged healthcare centers. In order to become an FQHC or a federally qualified health center, you have to meet a pretty broad range of requirements. And many of the health centers that are in the country now also have started offering mental health care, addiction services, dental care, and a pretty wide range of other services. So you'll see a lot of in-depth case management, outreach, translation services, health education, and such. So that really helps to do more of a comprehensive approach to healthcare, particularly, again, for underserved populations. Last year, we saw there were almost 1,400 health centers serving 27 million patients. Again, most of those patients were below the poverty line. And of those, there were about 300 programs that were dedicated to healthcare for the homeless and serving people who are experiencing homelessness. And then that was about just over 1 million patients that we saw last year. Now, those 1,300 health centers have got nearly 10,000 locations nationwide, about half of those in rural areas. So we really see a really good blanketing of the country in terms of safety net providers that are serving underserved populations living in poverty with a lot of co-occurring chronic and acute illnesses, trying to coordinate that care. So this is for me, this is a really robust and core part of our safety net. When we think about health centers and the opioid epidemic, there's a few things that I just wanted to talk about. One is the services that we offer that are specific to addiction. So healthcare for the homeless programs within the health center program at HRSA are required to offer addiction services. And this is a little different than non-HCH health centers, which might offer addiction services but are not required to. And so this, I think, has really positioned HCHs to be doing integrated care. We like to say we were doing integrated care before it was cool, because for 30 years we have been required to do behavioral health together with our primary care. But health centers broadly are required to regularly conduct needs assessments. And so when we're looking in our communities and determining what are the needs of the underserved patients that are coming to us, how is addiction, and opioid addiction in particular, figuring into the need in our community? What are the additional services that we can be offering in health centers to meet that need? How are we incorporating recovery and access to care and making sure that we're able to deliver on those needs? How are we incorporate that into our quality improvement plans? How are we tracking that data? So that's really important for us to make sure that we're offering high quality comprehensive care that really meets the needs of the community. And then the collaborative relationships, and I think this is really a key for this call too, is to think about how can we get health centers and housing and other COC providers to be working really well together so that we can maximize the expertise that we all bring to the table, knowing that not everybody has to do everything, but it is really good to be able to figure out how we can work together. From a funding perspective, there have been numerous funding opportunities that have come both to states and to health centers and other types of providers. Most recently, we've seen about $400 million awarded in September to nearly all health centers. And this was divided out in three, the biggest bucket just being basic funding to expand your mental health and substance use disorder services. Like, that's really where we're trying to go. We need more hands on deck, we need more space to do this, and we need more expertise. And so along with that came workforce training and education so that we can get our providers to really be experts at screening and identifying and treating addiction. And then, of course, there were some targeted grants for rural health. I think these offer a lot of opportunities for us in communities, not just expanding services, but that can include hiring and training new staff, professional development so that we're getting new skills into the primary care providers, doing more outreach. We're building in telehealth, which is particularly important for places that may not have easy access to providers. This money can be used to get new equipment. So if you need a mobile van or some vehicle that you can help with transportation, we know that often can be a barrier for folks accessing care. This also can be used even for little things like bus tokens, so individual patient transportation, purchasing Narcan so that we can have opioid overdose treatment right there, or just doing minor renovations. So that's just a short list of some of the opportunities that money allows us to do in the health center world, but it's the kind of thing that can also help maximize the community capacity for having more substance use disorder treatment. I'm just going to go through fairly quickly some of the data that we're really excited about right now is looking at the number of providers within health centers that have a waiver to prescribe MAT. And while medication-assisted treatment can take a number of different forms, typically methadone, for example, is very well known and a long-standing medication. But within health centers, we're primarily talking about Suboxone is the trade name, but buprenorphine is the typically the prescription that you need a waiver from the federal government, and only certain providers are eligible to take the training and do this prescribing. So we looked at the number of providers that have a waiver to do the prescribing for buprenorphine, and we took a look at the number of patients that were receiving these services within health centers. And what we found was that even though HCH programs are a very small portion of all of the health center patients, so you can see here about 4%, we actually are almost 40% of all of the patients in health centers getting MAT services. And it's really interesting to me to see HCHs be at the forefront of offering addiction treatment within a primary care environment, and really leading the way in what that can look like broadly for the field. And so I'm excited about some of the model of care that we've got, talk a little bit about today. And I will say that in 17 states, HCHs are actually doing more than 50% of all of the MATs for health centers in that state. So really strongly positioned to be a leader in doing lessons learned and training and professional development and all the things that I had talked about you could use that HRSA money to do. We've got trained providers already in programs that have got these already very solid and can, I think, be a resource in communities for figuring out what does this look like. Thinking too about the increases. So adding buprenorphine into a primary care environment is not without its challenges, but we've seen significant increases, even just from between 2016 and 2017. Health centers broadly increased the number of providers that had a MAT waiver by 75%. And HCHs increased by 82%, so like nearly doubling the number of providers year over year. And I would expect in 2018 we're going to see an even bigger jump. And so this is a rapidly increasing service that we are adding into health centers, and it's something that people are really getting into this business now and trying to perfect. In terms of patients, we saw a 65% increase in the number of patients for both health centers broadly and HCHs specifically, again, year over year. So excited about seeing that continue. At the same time, we're seeing really wide variation about what this looks like across states. Not all states are doing a lot of MATs. Not all states, though, are impacted by the opioid crisis in the same way. So we would expect that not all health centers would be providing the same level of services in every community, but we do know that in order to really be meeting community need, we have to have an honest assessment about what are the services that are needed in our community in order to really be participating in a healthy environment. When we looked at the number of patients that each provider was seeing, we average over the country for every provider is about 22 patients. And that's a very modest number, but again, health centers are providing a very wide range of services, and so MAT is just one of those. There are federal limits on how many patients a provider can treat, depending on whether you're a physician or a physician's assistant or a nurse practitioner. That can be as many as 275 patients, or it can be as little as 30 or 100. So again, depending on where you are and what type of provider you are. But this was a wide variation as well. Like some people were doing like a lot, like 50 and 60, sometimes even 70 patients per provider. And then other states you had literally less than one. So again, we've got room to maximize provider capacity. And what we really mean by that is access to care. So that's something that we'll be working on in the coming year. I had mentioned that not all states are impacted by the opioid epidemic in the same way. And so when you look at this map from the National Institute on Drug Abuse, you can see where we've got opioid overdose deaths concentrated, primarily in the Mid-Atlantic and New England states through the Rust Belt, and then a couple of states out in the West, primarily Utah and New Mexico. And so when we see this is 23 states that have got the highest over 15 per 100,000 people in terms of a death rate. In those 23 states, we have nearly 600 health centers. And so I think, to me, in my mind, this is a real good indicator of need. But when we look at those 600 health centers, about 330 of those have HCH grant dollars affiliated with them. Or almost 600 health centers, 300 of those health centers are not doing any MATs. And so that's one of the things that we really want to focus on. Of those 300 that are not doing any MATs, there are 60 healthcare for the homeless grants in there that are not doing any MAT. So I don't want to paint the picture that health care for the homeless grantees are always at the forefront. I think there's room for growth across all types of programs. For example, in West Virginia, which has the highest rate of opioid overdose deaths, we've got 27 health centers. 19 of them are doing no MAT activity whatsoever. And again, this is an area that might be growing rapidly, so we might be seeing more next year. But the data that was reported for 2017 just didn't show any activity. And in West Virginia, I had mentioned there's 27 health centers. 2 of those health centers account for 3/4 of all of the MAT patients that were served. And so we're seeing, again, some health centers that are really doing the lion's share on behalf of a state, but again, there's room for growth. And I think that this community on this call is really in a prime position to be thinking about who's prescribing buprenorphine as a primary care outpatient-based treatment so that people have access to recovery services. I want to just kind of go quickly too and just talk a little bit about the HCH model of care. And so while we are health centers and we provide all of the services that what we call regular health centers serving a generally underserved population, healthcare for the homeless programs tend to be even more of a harm reduction model. We tend to lower the barriers to access to care. We tend to be much more flexible when it comes to appointments. We tend to have our schedules be a little bit more flexible. We tend to make sure that we're tailoring a medical plan that really meets the needs of someone who might be living in the park or living outside and may not have access to a refrigerator for their insulin, or may not be able to carry needles into a shelter because the shelter will bar them from entering if they have any medical paraphernalia. So what does that mean for someone who needs to inject insulin on a regular basis? We try to accommodate that and make sure that people can adhere to their medical plan. Like I said earlier, we're doing more integrated care, and largely this is the needs of our population. People experiencing homelessness not only have greater rates of acute and chronic illnesses, but also of behavioral health conditions. And so it's, I know we've got other folks on the call that will be talking about, Rob and Melanie will be talking a lot about, the statistics behind behavioral health conditions. We see a lot more of that disproportionate rate in the homeless population. So thinking about how we're integrating care and making sure that people don't have to run all over town just to get the services that they need. I think one of the things, too, with our folks is our clinicians tend to be more comfortable with substance use disorder in general, and we have a familiarity with people who've experienced trauma and have really high needs and are complicated patients. And so I think we try to go the extra mile more so than you would see in the larger field, again, just because we've got a more complex patient population. Just really quickly here, we've done a lot of interviews with folks about why they aren't doing any MAT services, and for the folks that are doing a lot, what were the strategies that really helped them? You'll see a short list here, just hit really the highlights. A lot of the challenges come down to a couple of different things. One is people are really uncomfortable. The clinicians we talk to are uncomfortable identifying and treating addiction disorders, and particularly in a traditionally trained primary care physician will not have received a lot of addiction training in his or her career. And so this is a new area for them. And people with addiction disorders present in a different way. They need a different care model than some people are used to. And then that's a change that not everybody is comfortable with. I don't want to sugarcoat the fact that there is still stigma that is in our healthcare workforce, and there are some folks who do not want to treat people who have addiction disorders. So I think that's something that we need to be honest about, but we also need to increase our training and our discussions around that so that we can get beyond that. On the strategies end, I think we've found people have really talked about having successes in finding champions, starting small, adapting your workflow so that treating patients that may need more frequent but very short touches. So instead of having a patient that comes in for a 20-minute primary care visit, folks in the MAT program might just need a quick 5-minute check-in. So how do you adjust your patient schedules to allow for that? I think importantly, there's a lot of funding, resources, and training that's available from SAMHSA, from HRSA, and a number of other government agencies. And so maximizing that, I think, is really important. We have a lot of opportunities here that I think we all can maximize. And then quick, and I know I've gone over time, so I just want to make sure that I'm not taking away from Rob and Melanie's presentation. But the kinds of actions that we can all be focused on from both sides, from both the healthcare side and the housing side. If you're in the healthcare space, really think about how are you maximizing your buprenorphine services in your health center. If this is something that you're not currently offering, is this something that you could start, or is it in the plan? You know, what is the plan for addressing addiction, particularly opioid addiction, in your patients? How are you overcoming internal stigma and the discomfort with treating addiction? How are we maximizing the full care team? And that means community health workers, peer specialists, outreach workers, to complement the work of the clinical providers. And then how are we making sure we're working with hospitals and health insurers to make this as easy as possible? So we're taking away prior authorizations for Suboxone prescriptions, where emergency room physicians maybe can start someone on a medication and then refer them to us for treatment. So how do we get people quicker and easier access into opioid treatment? And then how might we be able to communicate with our patients' shelter or housing providers? How can we open up that dialogue with you? And then on the housing side, how can you make sure that your patients are engaged in care? How can you ensure that your policies and your program allow for medications, that we're not forcing people to choose between shelter and treatment, that these things can be working together? How is it that we're flexible to allow for people to attend frequent therapy groups? And then how is it possible that we could set up a communication chain with your patient's healthcare provider? So I think there's a lot of different things that we can be sensitive to here and work into our program. I'm happy to talk more about this at the end if this is something people want to talk more about. But in the meantime, I am going to hand this over to my colleagues, Melanie and Rob, to talk more about what they're doing for the National Association of State Alcohol and Drug Abuse Directors. So with that, I'm going to pass the ball to you, Rob, and thank you very much. And I'll talk a little bit more about the SUPPORT Act afterwards.
Well, I appreciate it. Thanks for that great presentation. And we're appreciative to be on this webinar demonstrating the work we're doing across different sectors on issues related to substance use disorders. My name is Rob Morris, and I serve as the Executive Director here at the National Association of State Alcohol and Drug Abuse Directors, or NASADAD. Just wanted to do a brief introduction before handing over presentation to Melanie Witter. She serves as Director of Research and Program Applications. But I'll talk briefly about the association and what we do and how we do it. From there, we've been around as an association since 1971. We're located here in Washington, D.C. As you can see, we're a nonprofit focused on education, scientific research practice, and evidence-based issues that our members face each day. As you can see, our mission is to promote effective and efficient state substance use disorder prevention, treatment, and recovery systems. And we emphasize that last aspect of prevention, treatment, and recovery is the continuum of care. And that's been an important focus that our members ask us to remind our staff here and our stakeholders across the board. So what do we do as the association? Well, like many, we are a membership-based organization, and they ask us to be their eyes, ears, and voice here in Washington, D.C., make sure that we're articulating what's happening in states regarding substance use disorders as they manage the publicly funded system. They ask us to make sure we're doing activities just like this, coordinating across groups to make sure we're educating about the activities moving forward in the states, how federal policy may impact our collective work. We also make sure we're educating people on innovations happening in states and educating people on what the core components of what state alcohol and drug agencies do, and to help our members help themselves do good work back at home. And finally, as we look at our role, I want to constantly remind us to educate the public, educate stakeholders, decision makers about the nature of substance use disorder, the benefits of prevention, treatment, and recovery, and to continue this collaboration to improve service delivery. So with that in mind, it's my pleasure to introduce to you Melanie Witter. A real benefit to us as she serves as Director of Research and Program Applications is also her background. Melanie did this. Melanie was a member of the association, a state director in Illinois, overseeing a large system with a number of complicated factors, and having that perspective here at the association is absolutely invaluable, both as we work with our own members, but as we work with our stakeholders. So it's my privilege to hand over the floor to Melanie. Melanie?
Okay. Thanks, Rob, and good afternoon, everyone. So what I'd like to talk to you about today is the role of the single state authorities for alcohol and other drug services, and also share with you some of the system resources that the SSAs, as we refer to the single state authorities, that they're overseeing and managing. Some of you may already be working with the SSAs, and for others of you, you may not know who the SSAs are or even have heard of that title before. So, this will be new information for you and a new opportunity for you to learn about who they are and hopefully for future collaboration with the SSAs. So in every state and territory, there is a designated principal or single state alcohol and other drug authority who is responsible for managing the publicly funded substance use prevention, treatment, and recovery system. But the purview of the SSAs may be and often is broader than just the publicly funded system. Very often the SSAs are also regulating and funding private services as well. So although they are all responsible for sort of safety net services, their authority extends beyond that as well in many cases. The agencies that the SSAs oversee are governed by, different statutes and regulations, and they vary in terms of their exact function and size and placement within state government. In some states, these are cabinet level agencies that report directly to the governor's office. In other cases, the SSAs are located within public health agencies or behavioral health agencies or health and human service agencies or Medicaid agencies. So, there's quite a bit of variation, and as we all like to say, if you've seen one state, you have seen one state. So in terms of the role of the SSAs, they wear several hats and they have lots of responsibilities. But one of their primary roles is to promote and ensure the highest quality of care. And so how they do that is by licensing care, by licensing services, treatment services, often recovery services as well, and by licensing and certifying the professionals that provide those services. They also develop annual state plans, and conduct extensive needs assessment and gap analysis. They also manage the Substance Abuse Prevention and Treatment Block Grant, which is a critical grant for all the states, and I'm going to talk a little bit more about that later. They also promote collaboration, which I know we want to talk about as well later, across state government and with multiple stakeholders. So, for example, working with the correctional system and providing treatment within, jails and prisons, and working with public health and the state police and the educational system and the Medicaid agency and child care. So multiple collaborative efforts. And then, of course, maintaining robust relationships with providers. There are a handful of states that do provide direct service, but the vast majority of services are provided by community-based service providers. And then, of course, the state SSAs and their staff collect and report data regarding substance use disorder services, and that is critical, and it's particularly critical during this opioid crisis. So what I'd like to do is, this webinar I know is focused on opioids, and certainly that is a very important part of what the SSAs are focusing on. It's a key part of their mission, and I'm going to share with you a fair amount of information that is specific to opioids, but what I'd like to do is also share with you broader information to put the opioid issue in context of other substance use disorder problems and the work that the SSAs do. So, just to provide you a little bit of information on substance misuse, and this is 2017 data, 66 million Americans aged 12 or over were binge drinkers. 16.7 million were heavy drinkers, and 30.5 million used an illicit drug in the past year. If we look at opioid misuse, you can see that 11.4 million people misused opioids in the past year. And the vast majority of those individuals misuse prescription pain killers, 11.1 million individuals, with 886,000 misusing heroin. We are starting to see trends that show that misuse of prescription painkillers are leveling off. We hope that we continue to see indications that this problem is leveling off. And I think that's due to better prescribing practices. Certainly there has been a lot of emphasis on that, lots of training, and lots of good monitoring that is occurring through, for example, prescription drug monitoring programs. Now if we look at, sorry, I didn't advance my slide before. Now if we look at substance use disorders, 19.7 million individuals 12 or over had a substance use disorder in the past year. 14.5 million had an alcohol use disorder, and 7.5 million had an illicit drug use disorder. When we look at this data, you can see that more than double the individuals had an alcohol use disorder than had an illicit drug use disorder. Alcohol remains our #1 problem. It has historically been our #1 problem, and it continues to be our #1 problem. If you look at illicit drug use disorders, marijuana is the #1 issue related to illicit drug disorders. But if we look at opioid use disorders, you'll see that 1.2 million people had an opioid use disorder, and 1.7 million people had a prescription pain reliever use disorder, with 700,000 people experiencing a heroin use disorder. If we look at the number of individuals who needed treatment and received treatment, about 12.2 individuals actually received treatment. And that percentage has remained fairly constant for a long period of time. It's increased slightly over the years, but over the last several decades, it hasn't increased all that much. For a long period of time, only about 10% of the population who needed treatment actually received treatment, and over the last couple of years, we've seen that percentage increase just slightly. And there are lots of reasons why people who need treatment don't access treatment. Some of those reasons are that they don't have adequate insurance or no insurance at all. Many individuals don't think they need treatment or are ready for treatment. And as Barbara mentioned, stigma is a very large factor still in individuals not accessing care. So who do the SSAs serve? This data is specific to the publicly funded system or the specialty system. A total of 1.7 million individuals received care in the specialty system, and you can see it's a pretty even split between individuals who are admitted for opioids and alcohol use disorders. And I won't go through the demographics here, but you can look at those. In terms of individuals who completed treatment or were transferred for further treatment, more than 50% either completed or were transferred. Only 28% actually dropped out. In terms of treatment for opioid use, you can see that 579,000 plus were admitted for opioid use, and the vast majority who were admitted to the publicly funded system were admitted for heroin use disorders. And of those individuals, about 25% had been admitted multiple times to the system. So as Rob had mentioned, the role of the SSAs is really to focus on a system of care, a comprehensive system of care, providing prevention, intervention, treatment, and recovery services. And how the systems look, their configuration, the service mix will vary a bit from state to state depending on their resources. But I just wanted to provide you an example of some of the services that are provided within the state. Certainly, the types of services are much more extensive than what I have listed here, but I tried to provide a few examples of the kinds of services that are provided and some specific services, and Barbara mentioned some already, that the states have implemented to address the opioid problem specifically, like Narcan and Espert, et cetera. Medication-assisted treatment, obviously. So now I would like to share with you some of the system resources that the SSAs are managing to address the opioid use crisis, as well as all alcohol and other drug issues, prevention, treatment, and recovery issues. So how is the system financed? Well, financing obviously does vary by state, but the Substance Use Prevention and Treatment Block Grant is a formula grant that is available for every state and territory. And I'm going to describe that to you in a minute. Here is a list of the other funding sources, and once again, you know, it's going to vary from state to state in terms of the availability of these various funding sources. But we know that the block grant provides $1.85 billion across the nation. State general revenue provides approximately about another $3 billion. Medicaid, with Medicaid expansion now sort of blossoming across the nation, it provides about another $10 billion. In terms of discretionary grants, those of course vary, but SAMHSA would be the largest funder of discretionary funding for specialty substance use disorder services. So what I'm going to focus on now are some of the grants that are available through the Substance Abuse and Mental Health Services Administration. So the Substance Abuse Prevention and Treatment Block Grant is really critical to the provision of services in the specialty system. As you can see, the purpose of the grant is to plan, implement, and evaluate activities that prevent and treat substance use disorders across really the nation. It's a formula-based grant, and it allows flexibility to direct resources to the state's unique needs. It really provides the foundation for the specialty system because of that flexibility to address all substance use issues. The block grant also provides a 20% primary prevention set-aside, which represents close to 70% of prevention dollars that are managed by the SSAs. And some SSAs spend more than 20% of the block grant for primary prevention. But others rely solely on the block grant for their primary prevention activities. One other comment about the block grant: although the block grant does provide a great deal of flexibility for the states to address their individual needs, including to address the opioid problem, it does have some very specific requirements that the states must address, including priority for pregnant women and making sure that services are gender specific. Also, priority must be given to persons who inject drugs, and tuberculosis services must be made available, and there are many other requirements as well. Two very important opioid-specific resources I'm going to mention next are the state targeted response grants, as well as the state opioid response grants. So the state targeted response grant, as you can see on the slide here, the purpose is to address the opioid crisis by increasing access to treatment, to reduce unmet need for treatment, and reducing the opioid overdose death rate through the provision of prevention, treatment, and recovery activities. The states are the eligible recipients of this grant in the same way that they're the eligible recipients of the SAPT block grant. the total funding for the STR grants in 2017, when this grant was first funded, it was $500 million, and then another $500 million was appropriated in 2018. These are formula grants, and the period for these grants are 2 years. Through the funding of these grants, states have been able to increase their capacity for services, particularly in the area of medication-assisted treatment, but they're also doing funding a number of very innovative services to address the opioid crisis. I also mentioned the SOAR grants, which have a similar purpose, new name, similar purpose, but you can see that the funding amount has increased for these grants. So the total funding in 2018 is $1 billion, and in FY 2019, $1.5 billion. Formula grants, once again, for a 2-year award period. The next grant, there were just 5 awardees for improving access to opioid treatment, and the eligible grantees were F2HCs, opioid treatment providers or practitioners who have a waiver to prescribe buprenorphine, and the Improving Access to Opioid Treatment grant is the purpose is to expand access to emergency treatment to those who are known or suspected of opioid overdose. So, this grant is to train and provide resources to healthcare providers and pharmacists on the prescribing of drugs or devices to provide emergency treatment. MAP-PDOA is a grant that's been around for a number of iterations, and the purpose is to expand and enhance access to MAT for persons with an opioid use disorder and seeking or receiving medication-assisted treatment. You can see who the eligible recipients of this grant are, and the amount of the awards and the number of awardees in 2018. This is also an extremely important grant for addressing the opioid epidemic. The 2 last grants that I'd like to share with you are specific for addressing the needs of individuals who are homeless. The first one is grants for the benefit of homeless individuals, and these are really to provide comprehensive and integrated services. So the first is to support the development and expansion of local implementation of community infrastructure to integrate behavioral health treatment for substance use and co-occurring disorders with permanent housing and other critical services for individuals and families that are experiencing homelessness, and the eligible grant recipients are public and private nonprofit entities, and you can see the funding amounts here for this grant. And then the last grant that I'd like to share with you is the CABI grant, which has a similar purpose, really to provide comprehensive and integrated care and treatment and social supports for individuals that are experiencing homelessness and chronic homelessness. A comment I would make about all of these grants is that In some cases, the SSAs are the direct recipient of the grants. In other cases, there are other eligible providers that are eligible to receive the awards, but in all cases, the SAMHSA awards must be coordinated and communicated with the SSAs. So it's very important to establish relationships with the SSAs that are responsible for the provision of specialty care within the states. So with that, I am going to turn it back over to Rob to close us out.
Well, we really appreciate this opportunity. As Melanie said, our goal is to help connect folks with their state alcohol and drug agency director. You know, it begins with a plan for the system, for the continuum, for prevention, treatment, and recovery. And as Melanie mentioned, the Substance Abuse Prevention and Treatment Block Grant for decades was that source of the foundation of the system. And from there, the states have processes for those plans, assessing what their need is and mapping out plans to narrow that gap between those who need services and those who are receiving services. So these systems have been established and are out there in states, and what we're trying to do is continue to reach out through these types of mechanisms to help connect folks back home to the leaders of the publicly funded system. And we've included at the end our contact information. And for folks who don't know your state alcohol and drug agency and you want to know who they are, please let us know. We're happy to go ahead and facilitate those connections because in the end, as people seek resources, it may be the state has initiatives moving forward already through that plan that I mentioned. And the federal funds are critical, but they also need to fit what the state is already doing to ensure that these are additive and helpful so that the system is coordinated and efficient. But I want to express my appreciation for participating on this webinar and look forward to continuing on working with you all on these issues. So we'll hand it back to the next speaker, and we'll happy to answer questions at the end or follow up as people seek to connect back home with their state alcohol and drug agency leader. So thank you very, very much.
Great, thank you. And so this is Barbara again, and I'm going to just follow up with a little bit about the Support Act and the priorities that we have had at the National Healthcare for the Homeless Council for what we believe is really going to be the components of a comprehensive response to really being able to kick the opioid crisis. And a lot of this is not specific to opioids. A lot of this has to do with substance use disorders in general. Again, we know that opioid addiction isn't always coming to us as the only drug that we're seeing. We're seeing increases in cocaine, methamphetamine, alcohol remains a problem and again, this is not specific to the homeless population. This is in the general population as well. And Melanie had outlined a number of the things that, Americans are still struggling with in our substance use disorders. But because we're seeing so many deaths due to opioids, and in particular fentanyl, we really wanted to tailor an agenda for what we know would need to be in place. So for these just 5 things on our list, as just an emergency response, we have to have access to Narcan. Our emergency responders need to be able to respond to people in the moment and have the supplies to do that. And so having the resources that allow them to make those purchases is really critical. So making sure that we have not only the supply, but the training and the policies at the local level that allow police, firefighters, emergency response to be able to administer that, and making sure that you've got good Samaritan laws in place fairly universally that make sure that you are not putting people at risk of criminal justice involvement for helping someone save a life. So I think those are all really important policies. Second, I think we really need to think about how we incorporate harm reduction principles throughout our healthcare system, not just specific to homeless populations, not just specific to alcohol and substance use disorders, but making sure that we're tailoring programs that really reduce the risk for folks to be able to minimize harm that might come to them. And so some of the things that we think about there are syringe exchange programs, safe consumption spaces. Even though we don't have those in the United States yet, internationally, we're seeing really good results, again, about saving lives and engaging people in care at really vulnerable places in their use. And so thinking about how we can be creative and really trying new things. As a third piece, very clearly, we have to be expanding the capacity. Melanie mentioned that 1 in 8 people who are in need of treatment actually receive it in a given year. That's something that we really need to be putting up on our dashboards as state outcome measures to really start to turn the tide on that. One of the biggest reasons why only 1 in 8 people get treatment is because they can't find a bed in their community. And that's for a variety of reasons. It could simply be capacity, or it could be that they can't afford that care. And this is particularly going to be an issue in states that do not have pervasive health insurance coverage. For this population, that's primarily through Medicaid. And so when we think about states that have not expanded Medicaid or don't have comprehensive coverage available to people who are low income, affordability is going to be a big piece that prevents or is a barrier to care. So thinking about how do we increase access, getting more beds, making sure that we've got more providers that are trained to prescribe buprenorphine. We're eliminating barriers like the prior authorizations that I had talked about. And for those who aren't in a clinical space, prior authorization basically means that when your physician or when your provider goes to write you a prescription for Suboxone for your treatment, they have to get permission from the health insurer to write you that prescription. And sometimes that permission can take up to 72 hours. That delay not only is a delay in access to care where you might have missed an opportunity to get someone in treatment, but it also creates a lot of administrative and regulatory burden for our providers who end up filling out paperwork rather than delivering care. So these are policies that we can waive, particularly for condition-specific prescriptions like opioid addiction. So those are some of the pieces, again, that we can be thinking about. What does that look like in your community? Making sure that our health insurance plans, particularly through Medicare and Medicaid, are offering a comprehensive range of prescription options. So buprenorphine comes in a number of different forms. That allows a clinician to be able to tailor that to your specific needs. But sometimes plans will only cover one form, or they won't cover any forms. And so these are the kinds of things that we see, again, as barriers to care. Fourth, expanding workforce opportunities. I think we've talked a lot about where providers are in their comfort level and in their training and core competencies to be able to engage in this space. So making sure that we have enough people at the right places, licensed at the right level of care, and that they are comfortable and trained and have the skills to be able to do this. So that's a lot. That's a lot of hiring and it's a lot of training. And then finally, thinking about funding for housing. We have to be talking about the social determinants of health if we're going to talk about getting a population healthier. It is very frustrating for us on the provider end to be providing the best quality care that we can, only to turn people back out onto the street or into a shelter space that is not conducive for recovery. And we're seeing people in outpatient and inpatient care do really great, and then not have the stability that we discharge them to. So they have no job, no place to stay, and then we wonder why recovery, why people relapse and why recovery doesn't stick and why recovery is so elusive for our most vulnerable folks. We don't give them the supports that they need. So how is it that we're making sure we're being comprehensive in the solutions that we're pursuing? So those are the 5 things that we're looking for. Now, the SUPPORT Act is only one piece of legislation that passed recently, and I want to say the SUPPORT Act has a lot of different components. This was a a very broad bill, but just from my perspective, if we were to be honest, it has a lot of things that are a series of smaller actions. I don't think that the Support Act is the kind of comprehensive approach that we want to see. At the same time, it does put in motion some very concrete steps forward that I think that we can maximize. And so putting the Support Act in the framework of the 5 things that I just talked about, when we think about the capacity for overdose treatment, there is more grants that are specific for Narcan and getting more first responder treatment in the Support Act. So we totally support that and are excited to see that. We did not see any provisions for specifically harm reduction programs in the Support Act, and I think that's probably not a mystery, given that some of those things can be fairly controversial. And in the case of safe consumption spaces, that's a very new idea that is still really uncomfortable for a lot of places to feel through. But if we want to be honest about harm reduction, that's something that I'm excited to see some of those conversations taking place. But the Support Act did not really address that as much. Where it did do a lot, however, is in this third space, in providing access to evidence-based addiction treatment. And we saw a number of areas. There were 11 areas that I will not detail, and I will not go through the detail here. But there were 11 areas that were sections in the legislation that were really exciting for us. In particular, a few provisions for Medicaid. One established a pilot project for doing some enhanced rates to states and giving states the option to be able to pursue higher reimbursement funding if they're doing more coordinated care. So that was exciting. We were also excited to see Medicaid provisions that allow for some Medicaid coverage in institutes of mental disease. And the IMD provision is what you might hear this called. Basically, this is inpatient psychiatric treatment. Now, this also comes with a lot of discussion around it. Disabilities rights advocates are rightfully sensitive to our nation's appalling history at institutionalization and the violations of human rights abuses that we have. And so we have federal protections, namely under the Olmstead Act, that require us to place people in the least restrictive care possible. At the same time, and because of that, what federal law prohibits is Medicaid payments in institutionalized setting. The idea behind that was to prevent the federal government from funding institutionalization in that way. Over time, however, what this has meant is that you don't have the capacity to be able to get people into treatment. And so we've seen this be a barrier to care. And so what this bill did is it opened up 30 days of Medicaid allowable reimbursements in those settings for substance use disorder treatment. And so it just opens a window. Again, I think it's important for us to be mindful of what institutionalization looks like, but for some folks that is an appropriate level of care. So we are glad to see some of that flexibility there. In terms of Medicare, Medicare can be a restrictive program. It wasn't designed as much with behavioral health conditions in mind. So the Support Act actually opened up requirements for Medicare to be including opioid treatment programs for the purposes of delivering buprenorphine, and allows that in the Medicare program, as well as creates a demonstration project that increases access for Medicare beneficiaries to substance use treatment, and then asks states to evaluate and develop measures, rather, to evaluate quality and outcome. So I think those are tangible state steps forward in our insurance plans. There were a number of other provisions that increase the availability of MATs, so predominantly Suboxone or buprenorphine we've been talking about. It expanded to additional types of providers, and it created more grants to be able to enhance access to buprenorphine. So that's good to see. And then finally, under this section, there was a couple of provisions that would support more access to family-based treatment. And the idea that we are not splitting families up when there is a substance use disorder, but how can we be doing more comprehensive treatment in a family setting? So I think that's really important. And I'm so sorry if this is more detail. I'm trying not to be too in the weeds. When we go into workforce opportunities, there were a couple of pieces here. One was asking the GAO to study how peer supports can help facilitate recovery. And I'm really excited to see more emphasis, again, being put on the full care team, community health workers, peer specialists, outreach workers. These are really core components of our care teams that can help engage people and keep them engaged in care. And then there were some provisions that were provided for loan repayments. And if you're in the healthcare industry, you know that loan repayment programs to be able to forgive loans for folks coming out of schools is a tremendous recruitment assistance. And so a lot of times it's hard for us to recruit people into these positions. So we're trying to get more folks with more training, and being able to help them afford that is really great. And I think it also provides an employment opportunity for many of the people that we are also with lived experience, either with homelessness or with substance use disorders or both. So I think this really can be a win-win for a lot of folks. And then looking at supporting training and technical assistance through HHS for a peer-run training and technical assistance center, and thinking about what that looks like. So provisions to set up more structure at the federal level to support that at the state level. Finally, expanding funding for housing. Now, to be clear, the SUPPORT Act did not include funding for actual housing. At the same time, it is asking HHS and some other federal agencies to be a lot more proactive and creative in how different programs that it administers can be facilitating housing stability. So, for example, there is a provision that requires HHS to do a report on how states are using their Medicaid program to cover housing support services. So that's exciting. It requires HHS to provide states with technical assistance to make that work well. It's requiring HHS to issue best practices for recovery housing. And so it may be that a number of folks on the phone are currently operating recovery housing models. Right now, we don't have any best practices nationally on what those programs look like. And so we know that there's a wide range of very high quality programs, but we also know that recovery housing can also be exploitive, and there's just really no parameters for what that looks like. So I'm excited to see that move forward. A couple of other provisions in the bill I thought are worth mentioning. It does require HHS to convene a stakeholder group to look at the reentry population and making sure that we're doing right by people who are engaged in the criminal justice system. How are they getting treatment and how are they transitioning into the community? A number of grants to FQHCs for training of providers. And then continuing the grants that many of us have talked about that are funding the states through SAMHSA or health centers through HRSA. So that's a laundry list. My apologies if that was too detailed. But I'm excited to see some of these provisions really snowball into something bigger. Just to wrap up really quick, if I can advance slides. We've got a few resources at the National Healthcare for the Homeless Council, policy briefs and webinars. If you want more information about all of this, we've got a number of things here. We've got a great fact sheet that my colleagues Elena Boyer and Brett Poe had put together in our research team about the opioid epidemic. And coming soon, super excited to see a new policy brief that we're doing with Kaiser Family Foundation that will put a lot more information to what I talked about earlier in terms of what health centers are doing with MATs and what are their challenges to getting that to capacity and their strategies for success. And then next fall, the council is looking to host a boot camp training opportunity where we can really be focused on pushing those strategies for success at a local provider level so that we can see those numbers of trained and waivered providers and services delivered to patients. We can see that really continue to increase in 2019 and 2020 and beyond. With that, I have rambled on enough. This is how to get in touch with me and the council. But at this point, I will turn it over to my colleague, Brett Poe, who can start us off on our conversation.
Great, thank you, Barbara. Yeah, so we are going to transition now into a discussion here. We've got some questions here for all of you, and this is to see where you all are and where more help may be needed, and most importantly, I think, is to learn about what best practices are working for you. They're broken down here. You can see them on the slide. The first few questions are relating to resources and resource management within your teams. The last few questions relate to how those resources then relate to your practice. So I'll be going through all of those with you, and while they're there on the screen for you to kind of digest and think on for a second, I wanted to open it up for a few minutes to get us started with questions that you may have for our panelists from their presentations. I've got some here from the chat already that I'll talk through first. And if you want to ask a question or respond to a question, I'll direct you to use the chat box in the web room. And if you'd rather respond or ask more directly, you can unmute yourself by pressing *6 on your phone or by clicking the little red microphone next to your name in the attendees list. And as a reminder, real quickly, if you do unmute yourself, just remember to mute again when you're not speaking. So to kick us off here, a couple of questions that we got from the chat. Our regional FQHCs, this question comes from Florida, are not providing MAT services. Our community has an addiction service shortage, and a few can talk numbers of uninsured. How can HRSA help us incentivize FQHCs to participate in high opioid use states? And Barbara, I think you said that you had a response to that question.
Yeah, so how we can encourage people to participate. Health centers are organized at the state level through primary care associations. So if you can identify who the primary care association is in your state, so for example in Florida, there are, let's see, I'm doing a quick check, there's 47 health centers in Florida, and 16 of those have got health care for the homeless funding. And so Florida served almost 1.5 million people in their health centers, and yet only served about 600 people with MATs. And I find it hard to believe that they only have 600 patients in need of this service. So one option might be talking with the primary care association to see who's doing the work, what training are they planning for the health centers that they represent, engaging more directly with the health centers in your community to say, hey, this is a need, what can you be doing? Or if the health center is dead set against doing this service, it is reasonable to engage them in a conversation about who will be. Health centers are still responsible for developing partnerships, doing the needs assessments, doing all those kinds of requirements that I talked about in the beginning. So really pushing people to be doing the services that meet their mission, I think is not at all inappropriate.
Okay, thank you so much, Barbara. And then another question that we had here, I think this is for Melanie. Who was the funder of the 5 awards that you mentioned?
The funder of the 5 awards is the Substance Abuse and Mental Health Services Administration. And the awardees, the awardees, I can't tell you right off the top of my head, but that is public information as well.
And Blake Benson has asked, many of my providers are worried about treating this population and still hold on to the stigmas associated with addiction. What is a good resource to break this barrier down?
This is Marcella. I'd highlight a couple of web-related resources. I talk about faces and voices in recovery. Just put in that Google, you'll find an organization that I think is growing to be one of the national voices in regard to recovery. There's also a great web resource a friend of mine participated on called I Am Not Anonymous. It is stories of people who are in recovery themselves, long-term recovery, commonly leaders in the field, but also telling pieces of their story and helping people understand, where people get to. We often, particularly in the homeless work, we see people at just their absolute worst, and it's really important to be able to think about how much they can grow from beyond that point. So I think some of those resources are important. And then given the training and particularly including in all of your trainings, if it's able to, the voices of people with lived experience, help them share, treatment works, recovery potential, things of that nature, and help them also talk about have them tell stories about if this is appropriate or true, a piece of their story where providers and, who reached out to them at their lowest moments and helped them get to the point where they are today. I wonder if any of the other panelists have any more details or any more suggestions.
Frankly, I think that when we talk about stigma and trying to create an environment where people are seeking treatment in a way that doesn't stigmatize them, I think we just need to be continuing to have an open and honest discussion. And I think that when we encounter stigma, much like anything, we need to be speaking up and speaking out and stepping up to say that we can no longer be treating addiction disorders differently than we do nearly every other healthcare condition. We don't kick our patients out of our diabetes clinics when they ate a bunch of cookies and their A1Cs and their sugars went all crazy, and then they went and had a number of emergency room visits because of out of control blood sugar. It never even occurs to us to kick those folks out of our programs. And yet when people relapse in drugs, many of our programs actually have policies that say, if you mess up, you're out. And I just feel like we have to get away from that. And I think that talking about that more and more, particularly the disparity in how we treat people with substance use disorders different than other disorders, has got to be part of that conversation.
Yeah, and building on that, the Surgeon General's report on alcohol, drugs, and health really does an excellent job on discussing substance use disorders like any other chronic condition, and so that would be a resource. Also, the Legal Action Center has a variety of webinars and other informational sheets that relate to stigma and addressing stigma. And one of their series, and it's a bit older, but it's very good, is called Know Your Rights. So even though it's older, I still think it provides really valuable information. And the other thing I would suggest in addition to sort of materials would be, engaging actual individuals with lived experience within your programs to help engage and support individuals. I think that's a very effective strategy to help raise understanding and reduce stigma as well.
Thanks. And with just a few minutes left, this really ties in nicely with the discussion questions that we have. And I want to continue talking with the panelists on this and a few other questions that we've received. But just to kind of summarize and invite participation from all of you who are able to summarize those resource-related questions, what we're really asking there is if you're using these resources or any others, how does that look for you at your site? What kind of representation do you have from your agencies on boards or with funding streams so that you are familiar and know how to get access to these resources and how to allocate the resources? And then as it relates to your practice, we're really asking how then do the resources or the policies related to those affect your practice, similar to kind of what Barbara was just touching on in the stigma, and if the policies surrounding that hinder how you really want to approach that, if it does hinder it. And then what recommendations then do you have on how to kind of navigate that and best apply these resources to your practice? So please, we really do invite you to give us your experiences there. And then also for the group and for the panelists, I want to ask, do we have enough providers currently trained in evidence-based practices for MAT? Barbara, do you know any of the stats on that, on MAT trainings and how that?
Oh, I'm sorry. There are a myriad of MAT trainings going on across the country. You're seeing not only states make that available, you've got professional associations making this available. Those grants that I talked about, as well as Rob and Melanie, facilitate bringing people into your clinic or other program and providing that training to your staff. So making use of that, not just for MAT and getting people their required number of hours to prescribe, but also bringing in training that does do destigmatizing, does increase core competencies in identifying, screening, and treating addiction, particularly in a primary care environment. There are literally thousands of consultant groups and all of this that have sprung up as a veritable industry that are tasked with bringing up the capacity of addiction treatment in the country. So I think that there's not just one place, I think there's many places.
Hi. So to respond to the second question in terms of do we have enough providers to provide medication-assisted treatment, I would say that we do not have enough providers to provide sort of any form of substance use disorder treatment right now. We do have capacity issues in certain states, not everywhere within the country, but certainly we do lack capacity for medication-assisted treatment, even though there has been this large influx of money and states are working rapidly to expand medication-assisted treatment. And as Barbara said, there's lots of training that is going on. And we have needs both within opioid treatment programs where they're providing both methadone and buprenorphine, as well as among WAVE physicians that are prescribing buprenorphine. Often, you know, WAVE physicians, they receive the waiver, they're, you know, eligible to prescribe buprenorphine, but then even though they're waived, we're not seeing them really treat patients or as many patients as they're eligible to treat. So we still have a lot of work to do in terms of capacity issues.
I think, and maybe to address that with a lack of providers, a question from Michelle Fundora has asked, how can telehealth be incorporated to help with this kind of treatment?
I think this can be a really good service, particularly in rural areas or areas where you just don't have any providers. The thing with telehealth right now, a couple of things. One is providers may not have the actual equipment and the services and the protocols set up to allow that, or the partnerships. So I think that's one thing that folks are working on, is figuring out how to get that in place, and then figuring out how this can be a reimbursable service. In a number of insurance plans, it has to be a face-to-face visit, and telehealth, we're still trying to catch up our technology with our policies. And so you're seeing states gradually increase allowing telehealth to be part of billable services. But Rob and Melanie, you might have some additional perspective on that.
Sorry. Telehealth is something that reimbursement is obviously an issue, but more and more we are seeing states use telehealth as a way to provide care to individuals that, in rural areas or have, issues with actually, accessing care within a treatment facility. So certainly telehealth is something that, provides, I think, a lot of opportunity to expand access to services. So,
one thing I would even add to this, and again, just kind of showing how these issues connect with so many other issues. Telehealth is going to be directly related to your broadband access in your area. And so when we talk about telehealth being really great for rural communities, many rural communities do not have access to the internet. And you've got to have broadband access in order to make telehealth work well. And so I think some of those technology pieces that are clearly outside the healthcare realm are the kinds of community infrastructure that is needed in order to make healthcare services work well.
I think just another thing to add to a potential benefit of telehealth is related to the thing we've been talking about with stigma. Just the comfort level of a patient who may be more willing to seek help or talk to a provider in that kind of format rather than going in and speaking to someone in person, I think is a huge factor. And we only have a couple minutes left. We'll kind of leave it open for about another minute or so if there's any other last-minute questions. And otherwise, I will go ahead and hand it back then to Marcella to close us out.
All right, Brett, thank you. I want to say just a huge thank you to our presenters, Melanie and Rob, Barbara, Brett, Sue, Jennifer, all our folks who put this together today. I really want to even more so say thank you to all the great folks who are on this call, who are learning about the resources, who we hope are going to take and go out and engage with their single state agencies and advocate for the best practices, expand their practices is our hope, and with the resources and supports that we've given as well. As I said, this is going to be a three-part series. We're going to have another webinar in February and then another in April. February is looking at systemic responses. April is going to be looking at particular program best practice models. So I've ended it here with Amy, thank you from CSH and National Healthcare for the Homeless Council as well. If you have ideas or interest, things you'd like to see on an upcoming webinar, my email and Sue Augustus's email is there. I think that is our last slide. Do I have that, or is there one more? Who's got the ball? Brett. So yeah, but stay connected, stay in conversation with us. Let us know if your great program is something that you want us to highlight, and we will be in touch. Thank you, everybody, and have a great Friday afternoon and a great holiday season. Thanks all.